We are live, please.
A very good evening to all and a warm welcome to everyone. So, at the outset, I take this opportunity to thank AIOS for giving us the opportunity for conducting the webinar on secondary glaucomas. A warm welcome to all the esteemed chairpersons, panelists, and speakers. It's a great honor and privilege to introduce the chairperson for today's session, Dr. Partha Viswasar, who is the President AIOS, Dr. Harsh Kumar sir from Center for Sight, and Dr. Chandrama Paul ma'am from BBI Foundation, Calcutta. I would also like to welcome the moderators, myself, Dr. Shweta Tripathi from Indira Gandhi Eye Hospital, Lucknow, my co-moderator, Dr. Mona Khurana ma'am from Shankar Netralaya, Chennai, Dr. Santosh Hunawar sir, who is Honorary Secretary AIOS, and Dr. Manoj Mathur sir, Honorary Treasurer AIOS. Now, I hand over the dais to Mona ma'am to introduce the expert panelist. Over to you, Mona ma'am.
Good evening, everyone, and thank you, Shweta, for the introductions. Managing glaucoma is rarely a linear path and it's challenging, but when we move into the realm of secondary glaucomas, the standard algorithms often fail. Today, we are joined by a distinguished panel of experts who have immense experience in navigating these turbulent waters to decode secondary glaucomas. So we welcome our panelist, Dr. Gursatinder Singh, sir. We look forward to his vast experience and immense knowledge. He's from Adesh Medical College and Hospital, Ambala. Dr. Kirti ma'am, an excellent clinician, researcher, and educator. Dr. Shefali Parekh from Triage Eye Clinic, Mumbai, whose presentations are always in-depth and she gives an in-depth insight into every topic. Dr. J.S. Bhalla from DDU New Delhi, who has immense experience in dealing with complicated cases, and Dr. Shibal Bhartiya, who makes complex things sound very easy. So let's dive into our first case by Dr. Preeti Kamdar.
Can I share my screen, please?
Yes, ma'am.
Can everybody see the screen and I'm audible?
Yes, yes, yes.
Yeah. So good evening, everybody. And at the outset, I thank Dr. Shweta Tripathi and AIOS for this opportunity. And it's a wonderful topic. Secondary glaucomas, no two cases are the same. And so this is one case which was very unusual, which I faced. So it was a spontaneous hyphema and with elevated IOP. So it was a 70-year-old lady, and she complained of sudden loss of vision, mild pain since one day. And there was no history of trauma, no diabetes, no blood pressure, no cardiac ailment. She was not on any anticoagulants. And the pain was not significant. Her main complaint was, I can't see. And the right eye was 6/24, and the left eye, I'll come to the pictures later. It was moving body with accurate PR. The right eye cornea was clear, AC was quiet. The iris showed atrophy, and there was a PCIL. She was pseudophakic. In the right eye, the pressures were 16, and in the left eye were 40. The fundus showed AMD in the right eye, and that's why the vision was 6/24. The old records which she had got with her. So in that also, the right eye was 6/24, but the left eye was 6/9 and N6 part. And the intraocular pressure was 16. No other details of past examination were available except for this, and it was 4 years ago. So now this is what we saw. And if you realize that this is the left eye, the eye which was 6/9 4 years ago, and you see there is a blood clot restricted only to the pupil. And then there is some kind of blood clot here. There is iris atrophy with defects, and there is little hyphema and some blood clot here. So it was not a full-fledged hyphema which could cause, but because of the place where the clot was, and that is what we were stumped. So whenever we have spontaneous hyphema, what do we think of? we think of these factors like what was the cause of hyphema. And because it was a very acute history, probably because the blood stopped, it completely occluded the pupil. And that's the reason why she came, because the vision dropped suddenly. So ocular causes could be uveitis, iris vascular tufts, tumors of the iris or ciliary body. All these I had to rule out because I couldn't see the posterior segment at all in the left eye. So I relied on the right eye, whether there was any kind of ischemia or any kind, because she was non-diabetic. So in the right eye, there was nothing. But these are the possible causes which can cause bleeding from the iris, CRVO, and proliferative diabetic retinopathy, systemic causes like blood dyscrasias, anticoagulant therapy. But in this particular patient, nothing really applied. She had done her blood test 6 months ago, where the CBC, the counts were good. She was not on any anticoagulant therapy. Whether there was CRVO or recent onset, I do not know, because I couldn't see the fundus. So of all this, the only thing which stood out, and I'll come to that later, is that there were iris vascular tufts. No matter, we did gonioscopy wherever I could do. There were extensive peripheral anterior synechiae, but I couldn't see any neovascularization. The B scan showed that the hemorrhage was restricted to the anterior chamber and the anterior segment. The vitreous was clear. The UBM also did not reveal any kind of any tumors or anything significant which I could attribute. She was pseudophakic, so nothing where you see the haptic rubbing against the ciliary body or the iris and causing bleeding. So with this in mind, again, on examination, I realized that there are 3 areas where the bleeding was restricted. One is completely occluding the pupil. Second is, if you see through this transillumination, this defect, you will find that there is blood behind the iris also. And there were peripheral anterior synechiae. It was a vascularized peripheral anterior synechiae, and that is where the blood on the iris was restricted to. And then there was hyphema. So what I thought was probably, and she did give history of rubbing the eye a little more forcefully around a day ago, and then she started seeing blurry. So I thought that maybe because of rubbing the eye, there was bleed from the peripheral anterior synechiae. Through this defect, it went posteriorly, and it went posteriorly, occluded the pupil from behind, and part of it also trickled into the anterior chamber, forming the streak hyphema. So this is what I thought was the cause. And first is we needed to treat the high pressures. So I started her on tablet Diamox, and along with timolol, primonidyl, brinzolamide, there was absolutely no inflammation. But no matter, I still started prednisolone eye drops and atropine eye drops in the hope that the pupil would dilate and the pupillary area would be cleared of the blood clot, and the patient would be able to see. But that didn't really happen. The pressure continued to remain between 36 and 40 on 2 separate episodes. And because the patient's good eye was involved, I had to intervene early because she was having trouble even navigating. And so that's why what we did was, this is a short video of what we did, that this was a blood clot. First, I went and tried to pull out the blood clot from the pupillary area, but it was stuck, as most blood clots are. And that's why I had to enlarge the incision and remove the blood clot in toto. So now the pupillary area was cleared. Now I am going behind the iris. You could see the blood behind the iris through the transillumination defect and the iris defect. So I went behind the iris in all directions, trying to extract the blood from all over the place. And many times we see that we remove the blood clot, but the next day you have liquefied blood still there. I did an intraoperative gonioscopy just to see if I could see something significant. Now, to prevent a recurrence, what I did was I filled it with viscoelastic, and I'm trying to just separate the peripheral anterior synechia just to prevent any further occurrences. But you realize that maybe my theory was right, and because it started bleeding as soon as I separated the PAS, separated the iris from the cornea, it started bleeding again. And so that's why I had to go back in again and try to remove whatever blood clot, because I also wanted the intraocular pressure to go down. And after some time, so gradually, if it clots and if you pull too much, it starts bleeding again. And that's what I'm attempting to do. And I put in an air bubble, but after that air bubble also, there was fresh blood. So I'm trying to remove the fresh blood again very gently, not really trying to pull on it. But I realized that if I become very, very aggressive, there is going to be bleeding continuously. So then again, I put in an air bubble with the hope that the air bubble will act as a tamponade, and the patient did very well. I gradually could taper the Dimox. I could, the vision, she regained a vision of 6/9. The posterior segment did not show any kind of involvement. And with a short course of steroid antibiotic eye drops and a short course of anti-glaucoma medications, her IOP, came back to normal. So this was an interesting case we had. And thank you so much for a very patient listening. And I'll now stop sharing and we can discuss this case further. Thank you so much.
That was a very interesting case, Dr. Preeti, the mystery of the blood clot. So I'd like to have Dr. Harsh and Dr. Shibal's take on it.
So I think it is a wonderfully presented case and great job done. I think let Shibal have the youngsters have the first say.
It's been a long time since somebody called me a youngster, sir. Thank you so much. That was really an excellent presentation, Dr. Preeti. It was actually wonderful to watch. When we see spontaneous hyphemas with elevated IOP, it does help to frame that as not just a one-time dramatic thing that happened. Glaucoma surveillance, finding out why that happened, and how do we prevent it a second time remains the crux of managing glaucoma as always. It is a follow-up disease. You will need to do serial gonioscopies, systemic workups. We will have to obviously start with identifying the cause of the bleed. In your case, you did very well. But what you mentioned, I think we just forgot to mention the juvenile xanthogranulomas in children. That might be one of the causes of, but this was obviously in adults. Apart from that, stabilize the pressure gently as quickly as you can. Avoid trabecular damage. Remember, inflammation is always a component. And an early intervention to prevent corneal blood staining is in order. You've done well. This was very, very elegantly presented. My congratulations.
Thank you so much. Thank you.
Okay, Preeti, just one or two questions. One because I always love the lasers, so I am just kind of putting forward. We could have just blasted that. Since you didn't mention in the this thing, your ultrasound and this thing, whether it was a pseudophakic or a phakic patient.
It was pseudophakic.
Pseudophakic.
It was that we later came to know. So if it is a pseudophakic patient, one can actually, even with a YAG, take that away, just for the sake of saying that. Okay. And second thing, what I thought was that, frankly speaking, it is never important to remove all the blood. As a matter of fact, to go into the periphery, remove all the blood is not important, because you will be able to control the pressure. It's not a full hyphema or something like that. And that central clot could also have been attempted by a cutter, because we have done this a couple of times, and it is so much easier to do it with a cutter once you know that the lens is there. It was a phakic patient, yes, we could have tried something else, but for this it beautifully comes out with a cutter. And like Sybil rightly said, so what is your theory for the especially, so does it seem like a uveitis causing peripheral anterior synechia? What was causing the peripheral anterior synechia?
I think it was a difficult surgery, because even the old reports, they just mentioned that there was peripheral anterior synechiae. So I felt that she was operated for cataract about, say, 15 years ago, and it might not have been a very clean surgery, causing, the vision was good, but causing peripheral anterior synechiae, and it was vascularized. So I thought that was the reason, and it bled, went into the posterior chamber, blocked the pupil, little bit dripped into the anterior chamber, and because that's the area where the clot was restricted to. So after removing it also, after follow-up also, there was no recurrence of the hyphema, and there was no inflammation. Even when she presented, there was no inflammation. There were no pigment cells. It was just blood.
I have a
So
very
I felt,
stupid question, Preeti.
no, yeah,
Allow me to indulge me
yeah,
on this
yeah,
one.
sure, sure.
What is just somebody who had a chronic angle closure and just presented with a hyphema? And what happened in the follow-up, which is why I said a longitudinal follow-up is so important. Sometimes you'll have to go back and trace
True.
what happened from what happens after your surgery.
So,
Were her pressures controlled
very
forever
much.
after you,
Yes,
without
forever.
any medication?
Without any medication. So it was just that one episode because she rubbed her eye. That's what I am assuming. Because otherwise, the PAS came back. I separated all of them, but eventually they do stick back to the cornea. And it was a little vascularized. But after follow-up also, when the cornea cleared, I could see everywhere. There were extensive PAS at multiple places, but nothing gross where I could see new blood vessels, which I could attribute to that it caused the hyphema. So, and without, I could stop all the AGMs. All the AGMs were stopped. So that's why after follow-up, retrospectively, I think it was just this one off episode of hyphema which caused the elevated IOP. And the disc was also healthy. I did fields also afterwards. So they were also healthy. So nothing to suggest that it was a chronic glaucoma with hyphema and then just exacerbation of the glaucoma.
Blood
And
works obviously was normal.
no. It was.
Okay. Thank you. That was really beautifully done. I just read something. I was quite surprised to see that obviously we elevate the head when if we get patients of hyphema, but I didn't. So it was also written that tell them to avoid seeing their mobile and doing near work, because that leads to rapid eye movements and that can actually increase the bleeding. This was something that I learned, so I thought I'll pass it on.
Actually, I would have waited, but the good eye was involved. The pupil was completely blocked. And for the vision purposes, I had to go in and intervene early.
So you didn't want to do a YAG?
No.
Why?
Can I interject if you allow me? Yeah. So I think this case has, iris atrophy patches, which could be attributed to the poor surgery, or could be maybe pre-existing uveitis was there in that case, which led to cataract. She has one eye pseudophakic, other eyes probably
Both eyes pseudophakic.
doesn't have a cataract. One eye cataract was there.
No, both eyes pseudophakic.
Both eyes, okay.
Both.
So maybe she had pre-existing uveitis or post-op uveitis. Maybe she had shallow chamber post-op, which led to peripheral synechiae. So there are multitudes of causes we can look into. So, but all said and done, she had peripheral, maybe she had some fixed kind of a thing, where she had vascularization which stayed on. So, lot of things can be there conjecturized in this case. Unilateral hyphema, without any retinal changes, without diabetic retinopathy, without CRVO, it has to be looked into, as some local cause. So I think has to be some maybe old uveitis or maybe some post-operative shallowing of AC or some post-op complications which have resolved, which came up now as hyphema. That's what I think about this case. And iris atrophy also substantiates that possibly she had post-op uveitis kind of a thing, or some maybe you are right saying bad surgery kind of a situation.
Okay, thank you. And I'd also like to ask Dr. Kirti for her comments on this mysterious hyphema. Kirti ma'am, can you hear me?
Yes, ma'am, she's logging in.
I think she's muted.
I think we should,
I am right now checking in. Just give me a I'm engaged. Just give me a moment.
I think Mona, she might not have heard the case, so we can move
Yeah,
on.
we'll go on to the next case. I think Dr. Shweta will introduce the next speaker. Ma'am, we'll ask you for your comments in the next case. You relax and check in.
So With that, we come to the second interesting case for today's session. It's going to be presented by Dr. Shainu Taya from Shri Shankar Dev Netralaya, Guwahati. And as usual, she has got a bouquet of interesting cases always. So over to you, Dr. Shainu.
Good evening, everyone. Thank you, Shweta. I'm just sharing my screen now. Yeah, I think it's visible.
Yes, it's visible. It's visible, Shainu.
Okay. So, a very good evening. So, I'll be presenting a case of secondary glaucoma post-optical PK. So, our patient was a 20-year-old male from Dhubri district of Assam, and he presented to us on 20th January 2025. He came with the chief complaint of left eye trauma with iron particle 6 months ago, and it was treated locally and a repair was done. So, on examination, the right eye findings were unremarkable. The vision was 6:6, and in the left eye, he had counting fingers close to face, and the cornea had a scar. The lens was cataractous, and the anterior chamber depth was shallow. Finger tension was increased. IOP could not be checked because of the corneal scar, and there was no view of the fundus. So, a diagnosis of post corneal tear repair scar and a decompensated cornea was made. Some of the preliminary investigations done were an ultrasound and UBM. The ultrasound was normal. It showed the lens echo in position and the vitreous was clear, and optic nerve head was mildly elevated, and rest of it, everything was normal. The UBM showed that there was zonular dehiscence in the temporal area. So the surgery for this patient was planned: optical PK, lensectomy, and an iris claw lens. Preoperatively, injection mannitol was also given. And in the post-operative period, the patient received topical steroid antibiotic, cycloplegic, and tablet acetazolamide was given for a short time. But on post-operative day 1, the vision was noted to be finger counting at 1 meter, and the FT was raised. Patient had also vomiting and giddiness. So tablet acetazolamide was increased, and injection decadron was also given. Actually, at this point of time, the patient was being seen only in the cornea clinic. So I could find from the file that IOP was checked only with finger tension. So only on the post-operative day 1, it was noted as raised. Subsequently, it was noted as normal. So post-operative day 4, vision had dropped to counting fingers at 50 centimeters. So a dilated fundus examination was done, wherein the disc was found to be hyperemic. There were vitreous cells, and vitritis was noted. So tablet Visolone was started. So in the initial few days, when the vitritis was not improving, the patient had a referral in the UVA clinic, and tab azoran was started 50 mg twice daily. So on post-operative day 14, the IOP was noted as 38, and the fundus was relatively clear, although there were occasional cells. And at that point of time, a timolol brimonidine fixed dose combination was added. After this, the patient was again seen at 1 month. At that time, the vision in the left eye was 618. With pinhole, it was improving to 69. And the graft was clear with a few DM folds, and the IOL was in situ, but the IOP had increased to 40 millimeters of mercury. The patient was still on anti-glaucoma medications. So he was referred to the glaucoma clinic and the UVA clinic. From the UVA clinic, the tab azoran was continued. So in the glaucoma clinic, IOP was reconfirmed to be higher, 38, with slightly distorted Myers, and the gonioscopy was open in all quadrants except the inferior, where no angle structures could be made out. And the optic nerve head was found to be healthy. Cup disc ratio was around 0.3:1. And in addition to timolol brimonidine fixed dose combination, the patient was also put on tablet Diamox, BDPC, 250 mg, and syrup glycerin was added for 1 week. So after 1 week, when the patient was reviewed again, the IOP had decreased to 20 millimeters mercury. So topical anti-glaucoma medications were continued. However, the patient did not come for follow-up as advised, and he came back only after 2 months. So when he came back, the vision had in the left eye was noted to be 624 with pinhole vision improving to 618. The IOP was still high at 38 with all anti-glaucoma medications, with one fixed dose combination of timolol and brimonidine and topical steroids as per schedule for a post PK case. It was going on. So a diagnosis of steroid response was made, and the topical steroids were tapered, and a prostaglandin analog was added. After 2 weeks, the IOP still remained at 32. We added another anti-glaucoma agent, and after 2 weeks, the IOP was still at 32. So despite medication, anti-glaucoma medications, the IOP could not be controlled. So since there was a medical failure, the patient was advised trabeculectomy with mitomycin. However, the patient was again lost to follow-up for 3 months. And after 3 months, when he came back, he had discontinued all anti-glaucoma medications, and his left eye vision had dropped to counting fingers, pinhole improving to 636, and the IOP was 46. The CDR had increased to 0.5:1, but the rim was still pink and it appeared healthy. So all anti-glaucoma medications were restarted, and trabeculectomy was done. So on the post-operative day 1, the vision was noted to be hand movement. As you can see in the images here, the bleb appears diffuse and congested, and there is blood in the anterior chamber, and IOP was 6 millimeters of mercury. So considering the hypotony, I changed the topical steroids to difluprednate along with the topical steroids and cycloplegics and lubricants. So on post-operative day 4, again, when the patient came back, you can see the hyphema had cleared, and the bleb also appeared less congested and diffuse, and IOP had improved to 10 millimeters of mercury. Then at 2 weeks, again, the patient came back, but the IOP had dropped to 4 millimeters of mercury. And as you can see here, the cornea is clear, the chamber is formed, and bleb is also looking diffuse. But the optic nerve head appeared blurred with blurred margins and tortuous blood vessels. So, however, there were no choroidal effusion. So this fundus photo was taken at that time. You can see here that the optic disc margin, optic nerve head appears hyperemic and edematous, and the vessels are tortuous. So after 2 months, the patient was continued on topical difluprednate, and after 2 months in tapering dose, and when he came back after 2 months, in between he had follow-ups, but in his last follow-up, that is after 2 months, vision had improved to 618 with a plus 4.5 diopter spherical lens. And then the IOP had also increased to 7 millimeters of mercury, and disc hyperemia had reduced. So the prescription, the final prescription was tapering dose of difluprednate for another 2 weeks, 2 times, and then 1 time, and then followed by loteprednol eye drop, considering his PK and lubricants. And he was also prescribed glasses and advised to review after 3 months. So this is the picture which was last taken when he visited us last month end. So you can see that the disc margin appears to have cleared a little bit, and the vessels also look straight. So the edema has resolved. It is still resolving, I can say. So why this case? This case I thought to present because if you can observe carefully, in the beginning I had said that the FT was found to be raised, but the patient never had a glaucoma consultation before the PK surgery. So this case had a high probability of post-operative IOP increase, which was overlooked in the beginning. Secondly, in a filtration surgery in a young patient carries a risk of hypotony, whereas in a post-PK case, because already a surgery has been done, so a filtration surgery carries the high risk of fibrosis. So it was like a double-edged sword. And in this case, somewhere balancing, probably I could not balance it that well. So the patient went into hypertony. And although he is recovering now, I don't know what is the long-term prognosis of this case. Thank you.
Thank you, Dr. Shainur, for such a wonderful presentation. I would request Chandrima ma'am and Shafali ma'am to give their expert opinions on the same. So we'll start with Chandrima ma'am. Shafali ma'am, can we have your expert opinion?
Yeah. It was very well presented, Dr. Shainur. Only thing is the few things which I would like to point out, that in this patient, see, when we are doing this in after optical PK, and especially this, the chances of increased pressure is very high. The reason is already patient had pre-existing glaucoma, because you said there was only slit AC, and patient had undergone some surgery beforehand, because of which there must be already a lot of pus. That is one thing. And these are the patients whom we do, if we do.
Ma'am, actually, although the preoperative gonioscopy was not done, after the PK, when the patient came to the glaucoma clinic, at that time gonioscopy revealed open angles, except in the inferior angle.
Yeah. You had a split chamber, so I thought it is already pre-pass. So these are the patients' chances of failure of the trap is also very high. So that is one thing. Means I am little bit means this patient has hypotony since long time, where you actually expect this patient chances of the after optical PK, the chances of high IOP is more. These patients nearly as high as 35% of the patient may get high, means patient can get secondary glaucoma. So that is one thing. And I think otherwise it was nicely presented. So regarding the hypertony, what I want to ask you is for how long you want to continue the difluprednate. And second, if you're you have mentioned steroid response when the patient came after post-op of the second visit. But what I feel that before, because patient is non-compliant, before that also patient actually didn't come for the follow-up, and when the patient came, patient had high IOP. So I will say that rather than the high pressure, because of that patient must be non-compliant, because again patient was lost for follow-up.
Patient was non-compliant that way because he never used to follow up as advised. But I mean, we have to believe the patient when they say that we have applied the eye drop.
Only thing is we always attribute things to steroid response. Of course, steroid response is a very important factor, especially after post-PK. And now, because this patient required optical PK, but now recently we have more and more people are shifting to DSAC and DMAC. And in this, the post-operative, that glaucoma, the risk of glaucoma has gone down tremendously. The chances of the graft, rejection is also very less, that I will say. But of course, this patient maybe required optical PK. So
this was a post-trauma case where he had a corneal repair. So it was a full thickness scar.
Yes. These are the patients actually who already have pre-existing glaucoma or pre-existing any case of trauma, chemical injury. These are the patients who are prone for developing the glaucoma after post-PK. The risk of developing post-PK glaucoma is very high in this patient. So I think we should always follow up this patient very regularly. That is one thing that I want to tell.
Yes, point very well said, madam. Sir Harsh sir just wanted your opinion, like as Shainur also said and madam also said, that the chances of failure of trap and post-PK glaucoma, the chances is high. So do we go for a valve, like a valve to be implanted on the very second, like first we go trap for a trap fails, we go for a valve. So is there any difference between a valve and a non-valve implant? For the pressure control or the control of the hypotony, anything like that? Do we have that?
So anyway, I am stuck on the valved implants because in my elite practice, they people cannot wait for the pressures to go down. And in the non-valved, so many times it will take 4 or 6 weeks for the sutures to get out, and even if you want to pull. So we actually don't have much experience over there. But obviously, what the literature says is that okay, you can go ahead and they have a long-term more greater success for the tube part. One more thing I just wanted to check, Shainur. So, what exactly did you think was the cause of hypotony? The question is that now we are getting a lot of patients with hypotony post-TRAB and whatever. And one point is that if you do the OCT and the folds in the retina, when they start tagging together, that is the time when I caught my retina pan and he said, okay, you can wait for a year also, it doesn't matter, and let it resolve. But if the internal thing in the UP in this thing OCT, you see that they are getting attached to each other, that will create a big problem, because later you will have to go for a
Yeah.
major
So
surgery.
in this patient, sir, I have shown the fundus photo. There was definite improvement, and there was no maculopathy as such. There were no stria in the macula. Just the disc edema was there.
Right. So, what according to you was the cause of the
Sir,
hypotony?
I don't know. I
There was
think
no
maybe
there was no
the fear
overfiltration.
of failure. Maybe I was a little over enthusiastic, and maybe I did not tie the. I don't know. I mean,
Can I
that's
add
what I'm
something?
thinking, because I just highlighted that point, that it was like a double-edged sword. I had the risk of hypertony in a young patient and the risk of fibrosis of the bleb because of the PK. So I had to titrate somewhere in between. Maybe
So
that
the
went.
bleb currently, is it overfiltering?
No,
It's not.
the last picture I have shown, it's a
Yeah.
diffuse, normal-looking bleb, not overfiltering, sir.
Is it possible that because it's a case of trauma, and
Yes.
another, if the graft size and this we have no idea, so can there be any cleft which we are missing out? That is one thing.
Yeah, even I
And
was going to say the same thing.
and
Yes, ma'am.
second thing is, here in such type of cases, especially post-traumatic and secondary glaucoma, I also prefer valve surgery. That would have been my first choice rather than trap, because the chances of the trap failure post optical PK is high, and because of trap chances of the graft failure is also high. That is vice versa.
And bus only point what I am getting little confused here, ma'am. Had a cleft been there, the pressures would have not risen to that amount. Like
Yeah.
40 she had shown at one point. So if the cleft was there because of the trauma, then the pressures would have been low from the very beginning. Could be
It's
surgical.
quite possible, if after trauma, if the cleft is closed because of maybe atropine or something, if you are giving, then pressure may shoot up. And maybe after surgery the cleft has opened up. That is another possibility.
Gonioscopy did not reveal any cleft, only one angle was not seen. There was synegia.
This is just one of the theoretical possibility.
Yeah.
It is what, because the hypotone is too much, and here this patient needs to be followed
And
for the.
is it also possible, ma'am, that because the patient had a previous history of trauma, that is also possible for, I mean, that could also be a reason for hypertony?
Trauma patients, yes, trauma patients can behave, but only thing is trauma patients and optical PK, both of them are like, they predispose more to the high intraocular pressure. So that is the only thing, that this hypertony is prolonging, it is for a long time.
Yeah. But interestingly, the bleb was also not overfiltering.
So that means that is again not the reason for hypertony.
Right.
Yeah.
No, sometimes you can't really make out, sometimes those
Yes.
blebs are actually diffuse, and it was a diffuse bleb, and sometimes they are overfiltering, but we can't make it out. And then the other thing left is the ciliary body atrophy to some extent,
Yes.
that anyway you are giving steroids for that.
And just my question before we conclude for Shainu's case would be to the panel and the chairperson. Like in these kind of eyes, no, she has said that it was a steroid responders, and we have to prevent the graft from failure. And now the cornea people, to prevent the graft from getting failed, they put the patient on long-term steroid. So what is the rescue as in glaucoma person from our side? What do we do? We put the patient on cyclosporin, or how do we go about it? Because many a times I have seen that I ask them to stop the steroids. They are restricted because of their own prevention of graft failure. So Harsha, what is your take on to that?
Can shift to the low dose steroids, because these patients are on steroids for long term, more than a year sometimes. So usually if the patient is showing tendency for high intraocular pressure, most of the time we shift patient to the low dose like clotiprednol or so. And what I said, I think mostly in our practice, rather than optical PK, we are seeing more of DSEC and DMAC patients. So in those, anyway, the chances of glaucoma is very, very less compared to what we see the optical PK. So I think those who are seeing more of optical PK means they can, I think Dr.
With a
Kavita.
filter in place, with a filtering surgery bleb or a trab in place, the chances of a steroid response are blunted. So you don't have to worry so much if you have, and in a post PKI, it's always better to put in an implant. A shunt is the way to go. I think everyone will agree. And what impacts graft survival most is where you're putting the tube. Whether you're in the sulcus, whether you're in the pars plana, whether you're in the anterior chamber, that is a more critical question. And I think that's something that Dr. Harsh should answer more than anything else.
Most of our PKs, we will put a posterior tube. We will go in the pars plana through
So a
the
tube is,
weight test and do this. Yeah.
If the panel was to give a directive, I think Dr. Harsh will say this without any hesitation. It's always better to do a shunt in a patient of post-PK glaucoma. And it's best to put the tube as posteriorly as you can, because then you are actually taking care of graft survival. And steroid response is not much of a consideration once you've put in a surgical device in place.
Yeah, can I say something? Only
Yes,
thing in this patient, I would have preferred, yes, a patient is pseudophakic, always in the posterior segment. But here, because patient has iris claw lens and most probably because PC is not intact. So in that case scenario, if you put in the posterior chamber, so then the chances of vitreous tugging is very, very high. So that thing we have to take care.
No, you have to do a complete wit. You have to actually
pass.
PVD and then do the whole thing.
That has to be taken care of.
We always do this. There's no question, because we have suffered 2 times for the PVD later came up and blocked the tube.
Yes.
So you have to do a complete wit whenever you're putting a posterior valve.
Right.
Well, we can move on.
Yes, sir. So with that, we move on to the third case for today's case series. And before that, I would like to share with everyone that Dr. Santosh sir and Dr. Manoj sir, they are busy with the AIOS work in office. So they won't be joining us for today, or probably a bit late. And with that, I hand over the dais again to Mona ma'am to introduce the third speaker.
So I now invite Dr. Kavita, who is an expert in dealing with challenging cases, to share her challenging case with us.
Thank you, Mona, and thank you, Shweta and AOS for the opportunity. So I'm just sharing my screen. So at this outset, I would like to, are my slides visible? Mona, are my slides visible?
Yes, they're visible.
Thank you. So I would like to thank my retina colleagues as well, who helped me with establishing the diagnosis. I'll be presenting a case series of Bestrophinopathy with angle closure glaucoma when the best turns worst. So I'll be presenting a case series of 3 patients. Our first patient was a 50-year-old female who presented to us with gradual progressive loss of vision in both eyes for almost 2 years. Her best corrected visual acuity was 6.6. Intraocular pressure was normal. Based on the fundus findings, she was diagnosed as Best disease, Best vitelliform macular dystrophy, and she was advised to undergo EOG and ERG. However, she was lost to follow up, and she again presented to us like a couple of years from the first presentation with sudden painful onset of defective vision in her right eye for 2 days. She gave history of undergoing laser peripheral iridotomy elsewhere, and also she had undergone phacoemulsification with intraocular lens implantation almost a couple of weeks ago before presenting to us. She was on anti-glaucoma medication, cycloplegics, antibiotics, and steroids. So on presentation, she had a real flat AC with iridocorneal touch. The angles were closed in the right eye. Her vision was 5/60 in the right eye. Intraocular pressure was 27. Left eye had an occludable angle. The rest were normal. So her fundus examination showed vitelliform dystrophy. Her B scan was normal. EOG was unreliable. ERG showed normal scotopic but reduced photopic response. And However, following day, her pressures raised to 47 millimeters of mercury in the right eye, even with medical management, and in the left eye it was 16. The OCT showed subretinal hyperreflective deposits, which was suggestive of Best's disease, and she was diagnosed to have aqueous misdirection and in the right eye. Secondary angle closure glaucoma, and in the left eye she had PACS and Best's disease, Best vitelliform macular dystrophy in both eyes. She underwent IZHP, following which she completely recovered with a vision of 612, and the intraocular pressure also got normalized. So moving on to our second patient, she was a 35-year-old female, and she presented with a visual acuity of 624, and her presenting intraocular pressure was 27 in the right eye and 39 in the left eye. She was diagnosed to have primary angle closure glaucoma, and she underwent laser peripheral iridotomy and was started on anti-glaucoma medications. And during follow-up, we had to augment the anti-glaucoma medication since the intraocular pressure was not getting controlled. And these are her fundus images, which showed a healthy disc in the right eye. On the left eye, there was a near total cupping, and the macula showed CSSR sequelae. This is the OCT image of the macula, which showing a shallow neurosensory detachment with the thinning and the loss of the photoreceptors, which was suggestive of CSCR sequelae. So during follow-up, like we had to augment the medications, including we had to put her on oral acetazolamide since the pressures were not getting controlled. She was advised to undergo trabeculectomy in her left eye, and it was uneventful. However, on 12th post-operative day, she presented with sudden onset of pain and defective vision in the operated eye, and the vision dropped down to 5/60, and the intraocular pressure was 51, and she had a flat anterior chamber with the iridocorneal touch. She was diagnosed as left eye aqueous misdirection syndrome. She underwent parsplanar lensectomy with vitrectomy and IZHV, and post-operatively, her pressures were very well controlled. So following the development of aqueous misdirection, we wanted to revisit her macula and fundus changes. The repeat OCT showed ellipsoid zone loss with foveal thinning and thickening of perifoveal photoreceptors. So this is the autofluorescence, which showed granular deposits, which was hyperautofluorescent near the arcades in the mid-periphery, and the hypoautofluorescence in the macular region, which was suggestive of bestrophinopathy. Her ERG showed normal scotopic and the photopic response, and EOG showed reduced Ardens ratio, and these findings were also suggestive of bestrophinopathy. So our third patient was a 35-year-old male, and he also presented with defective vision in both eyes. His best corrected visual acuity was 636. Intraocular pressures were high. Right eye was 28 and the left eye was 46. And he was also diagnosed as angle closure glaucoma, underwent laser peripheral iridotomy. He was also started on anti-glaucoma medications. Following iridotomy, there was though some amount of opening in the angles, the anterior chamber remained shallow. So during the follow-up, we had to augment the anti-glaucoma medications. This shows his fundus images, and he had a advanced near total cupping in both eyes, and we can see the background retina showing diffuse RPE mottling at the mid-periphery along the arcades. And since his intraocular pressure was not getting controlled, he was on almost maximum possible medical therapy. He was also advised to undergo trabeculectomy. And this is the autofluorescence, same like the second patient. He had hyperautofluorescent deposits along the arcades in the mid-periphery and hypo in the macular region. The OCT showed sciatic retinal layers of the macula and subretinal hyperreflective material, thickening of perifoveal photoreceptors. And ERG showed severe reduction in both scotopic and the photopic response, and ERG showed reduced Ardens ratio. And this patient, we did the genetic testing also. He tested positive for BEST1 gene, and all these features are suggestive of bestrophinopathy and angle closure glaucoma. In the meantime, we came across this publication and we contacted Dr. Sirisha Sendil from LVPI. She connected us with their retina team as well. And in this paper, they have published a case series of 6 patients, and 5 out of the 6 patients had intractable glaucoma despite the peripheral iridotomy. All the 6 patients developed malignant glaucoma aqueous misdirection following a filtration surgery. They responded only to debulking of the vitreous along with IZHV, and the resolution of the angle closure following IZHV, they suggested that there is a possible underlying vitreous pathology, vitreopathy in these patients. They have also done a complete genomic analysis and mutational typing for all these patients. Actually, first, when I presented the second case, I said the diagnosis was CSCR sequelae. When we saw the third patient and this paper, we realized that we are missing something, and we were wondering why the patient landed up in aqueous misdirection. And we could correlate the findings and revisit our diagnosis after we saw our third patient. And this patient, after consulting Dr. Sirisha and the LVPI retina team, and since they have also come across 6 such patients, they suggested us to avoid trabeculectomy and to go ahead with clear lens extraction with the intraocular lens implantation along with ISHV. The surgery was uneventful. Post-operatively, the patient did well, and he is doing now very good with intraocular pressure of 14, and he's on one single fixed combination. Seeing the response in one eye, the fellow eye also the same procedure was done, and now he's on a single fixed combination with the pressures in the lower teens. This is a pre-operative ASOCT and the A-scan picture and the IOL master showing reduced anterior chamber depth, which was around 2.88. Post-operatively, we can see a very good deepening, both in the ASOCT image and the slit lamp image, and the AC depth increased to 4.37 millimeter. In the right eye, pre-operatively, it was 2.77 millimeter. Post-operatively, the chamber depth improved to 4.37 millimeter. So all the 3 patients had features suggestive of Best disease or Bestrophinopathy. All 3 had angle closure glaucoma. 2 patients developed aqueous misdirection following an anterior segment surgery. Third patient filtration surgery was proactively avoided. Instead, phacoemulsification with IZHV was considered. So moving on to further literature search, this is a paper which is describing a family with a mutation in the BEST1 gene and Best vitelliform macular dystrophy. And they have suggested the anterior segment abnormalities are common in these eyes with shallow anterior chamber, closed, narrow angles, and angle closure glaucoma. And they have also proven the fact that it is very crucial to evaluate the anterior segment, periodical gonioscopy, and the intraocular pressure evaluation in order to see and look for glaucoma. Just to conclude, this is a rare association between angle closure glaucoma and the Best disease or bestrophinopathy. To establish the diagnosis, as we saw in these case series, multimodal imaging is needed, including fundus imaging, autofluorescence, OCT, and along with a genetic analysis, which plays a pivotal role in these patients in establishing the diagnosis. It is good to avoid anterior segment surgeries alone, and if needed, it should be considered along with ISHV. Thank you. Thanks for the opportunity. I'll stop sharing and open the case for discussion.
Yeah, that very interesting case, Dr. Kavita. So there are 2 challenges here. First, to reach to a correct diagnosis that it is best. We know it can be misdiagnosed. Even we have a publication where it shows how in cases it has been misdiagnosed as CSR and other conditions. So once we know the diagnosis, we know that it is associated with angle closure and a high chance of aqueous misdirection. So I'd like to ask Dr. Harsh here that once you know that these eyes are prone for aqueous misdirection and you need to go in even for a cataract surgery like Dr. Kavita showed in the first case. So would you take any preoperative precautions or would you directly go in for the full?
Better give a chance to Kirti now, since you are looking for her.
Okay. I
Go ahead.
think
Kirti should comment.
is she is
She's
traveling,
lost
I think.
connection. She's flying, I believe.
Traveling, I think. So I mean, then
Okay,
any
then that is a little tricky, to go ahead full-fledged. Let's start from the beginning. Uh, Many of these cases you do a PI, okay, because they are crowded angles, and there are a couple of papers which say that yes, a number of them may actually having plateau iris also. So once you are doing a PI, please go ahead and do a iridoplasty as well. And many a times that does quite a good part as far as the beginning cases are concerned. Now, yes, doing a cataract, and should we do and go ahead a vitrectomy along with that, or iridozonal hyaluronic, this is a little tricky part. I think if you put them on atropine, just do the cataract, maybe thinking that yes, maybe they'll go, but I don't think all of them will land up like that. maybe we
Yeah.
got the presentation over there. I think Kavita can clarify what is the total percentage if you take.
Yeah.
Kavita, what is the total
So
percentage?
actually, so actually in the case series where they presented in LVPA as well, the 6 cases, all the patients following an even they did the PI, even they managed medically, none of them responded to medical management or atropinization, and they all responded very well to IZHV. And after IZHV, there are some of the eyes which needed PK and then AGV. And during the second surgery, since the unicameral establishment got blocked and there was a membrane blocking the IZHV site, there was in almost 2 patients the aqueous misdirection recurred. So that's why we said it's not always go ahead and do the IZHV. But once if you have all this multimodal imaging ready, along with the proven genetic analysis, then I think it's a great idea to go with IZHV, because most of these patients are very young. So I could also come across another publication where they said, again, here the problem is not the iris, the problem is not the angle, the vitreopathy. The vitreous, when it is the gene which is associated with these anterior segment abnormalities, there is which regulates the transmembrane protein, which also regulates the fluid flow within and outside the vitreous. So when it is very solid, it really blocks. In one of the papers, they have said that they had a patient where they had to do a clear lens extraction. I think this is by Dr. Ningley Wang, published in, I think, 2019, where they have done a diode CPC. And they said they could visibly see liquefaction of the anterior vitreous phase. So unless until we handle the solid vitreous and make it liquefy, these patients are not going to respond. Actually, when we saw the first and the second patient, we did not realize this rare association. It's only after when I saw the third patient, we learned about this association and we had to revisit our diagnosis. And they had a classic clinical picture, and we are also planning for genetic analysis for the other 2 patients as well. So when I discuss with my colleagues in other Arvind centers also, they also have 2-3 patients like this. And they typically present with aqueous misdirection. But in one of the cases, as you said, that resolved with medical management with atropinization. But these eyes are, with any further intervention, they are prone to have a recurrent aqueous misdirection, which will naturally land up in IZHV.
Chalo, thank you so much. I think we all learned something very interesting over here. So please, Mona, go ahead here.
Thank you, sir. Thank you.
Pali, what are your comments on this? One option is to go full on. Other option, if you do one eye with taking the proper preoperative precautions, like sir said, and then if that eye develops aqueous misdirection, then you go for the other eye, and then go do IZHV in that eye. So is that an option, or you would still go all the way?
Mona, for the genetic test is proving, and these eyes will 100% land up in aqueous misdirection. These are not the routine primary angle closure glaucoma eyes. These are secondary angle closure. They are supposed to have retinopathy when they are clinical features suggestive of the autosomal recessive bestrophinopathy, along with the established genetic analysis. I think with all the publications, the limited publications, whatever is available, it is good to consider IZHV and bring down the pressures as early as possible.
Because we've had a couple of cases where we've got away with just trap. That's why I'm asking. So, but if it happens in one...
You did genetic analysis in these patients?
Yes. There's one young patient.
Genetic analysis?
Yeah.
Mm.
It was one patient I can quote, where we got away luckily with. We were fully prepared, but we got away with the trap.
Wonderful.
So can we move to the 4th case for today? That's going to be presented by Dr. Debashish Chakravarti. He's from Center for Sight, Calcutta. And over to you, Dr. Debashish. He's going to talk about a very interesting case about the Sturge-Weber syndrome. So over to you, Dr. Debashish.
Yes, yes. Thank you, Dr. Shweta. A big apology for the sore throat I'm having. Good evening, Harsh sir, and all the senior faculty here. So I'll be discussing a case of glaucoma associated with Sturge-Weber syndrome. And so, yeah. So this was an 11-year-old boy who was referred to us from Mizoram. And the right eye was diagnosed as glaucoma associated with Sturge-Weber syndrome, and he has been advised trabeculectomy elsewhere, and he came for a second opinion. So on examination, we can see that there is a visible port wine stain involving the right side of the face, including the eyelids, and the ocular examination revealed dilated and tortuous episcleral vessels. The vision was 618. He was having RAPD in this eye. The pressure was 40 millimeter mercury. So this patient actually was seen about 10 years back. This case is about 10 years old. And then the Rho kinase inhibitors were not available. And the patient was on latanoprost, dorzolamide, and timolol. And gonioscopy showed open angles with blood in Schlemm's canal. Optic disc showed 0.8 cup with thin superior and inferior rims. The fundus examination showed diffuse choroidal hemangioma, and this was most marked at the posterior pole. Perimetry was unreliable, and the B scan showed diffuse choroidal thickening. As you can see that there was thickening of the choroid, and this was a possible choroidal hemangioma. So a brief overview of Sturge-Weber syndrome in general. We know that Sturge-Weber syndrome is a non-familial sporadic disease, and the incidence is about 1 in 50,000. This is a congenital neurocutaneous vascular syndrome, and it potentially involves 3 organs: the skin, the eye, and the brain. So in the skin, the most constant feature is a port wine birthmark involving some portion of the trigeminal nerve distribution. The brain findings are ipsilateral leptomeningeal angiomatosis with brain atrophy, seizures, and developmental delay. And in the eyes, it's associated with ipsilateral choroidal hemangioma in 40%, glaucoma in 30%, and prominent epibulbar and conjunctival vessels. So the glaucoma is what we are most interested in, and it's ipsilateral glaucoma seen in 30% of cases. And the most worrying thing is that most of these cases, or all of these cases, will require surgery, and the surgery is complicated in many cases with choroidal effusion or suprachoroidal hemorrhages, and in many cases there is postoperative hypotony. So what are the surgical options? So we know that there are 2 types of Sturge-Weber syndrome, or 2 modes of presentation. One is the early onset glaucoma, where there is a congenital anomaly of the angle. So here the treatment of choice is some form of angle surgery like a goniotomy or a trabeculotomy or a combined trabeculotomy with trabeculectomy. Or we can have a late onset glaucoma like the child we have here. So there it is associated with raised episcleral venous pressure because of the abnormal vessels. And here the options are trabeculectomy with MMC or the glaucoma drainage devices. Now, if you consider trabeculectomy, there's a high risk of choroidal effusion and suprachoroidal hemorrhage. And the literature shows that as many as 10 to 40% of patients may have choroidal hemorrhage and choroidal effusion post-trabeculectomy. Ahmed glaucoma valve is also a well-known treatment modality for these cases, and some studies have shown that there is a less risk of the choroidal hemorrhage when it's treated with Ahmed glaucoma valve. So we planned AGV, pediatric implant, that is FP8, under general anesthesia. Now the most important point while doing Ahmed glaucoma valve in these cases is that there has to be certain precautions. So preoperative IV mannitol or on-table intravenous mannitol. Now perioperative propranolol is now considered to be helpful, but 10 years back it was not very common. So nowadays many surgeons start with propranolol about 2 milligram per kg body weight, and they start about 1 week pre-op and continue it for another 6 weeks post-op. Prophylactic sclerotomy have been shown in certain studies to be helpful, but certain studies have shown that they may not really cause any difference as to the final outcome. So we did not go for the prophylactic sclerotomy. Now, two such surgery like a Barvelt implant or an ADI implant is also considered an option. But then again, the immediate postoperative IOP will be high, and that might be difficult to control. So intraoperatively, we have to make sure that the closure takes place soon after the tube is inserted in the eye. We have to keep the scleral patch graft trimmed and ready and take as little time as possible after the tube is inserted. And very importantly, we keep intracameral viscoelastic inside the anterior chamber after the surgery, and this helps reduce a postoperative hypotony. We continue the cycloplegics slightly more than usual, maybe up to 3 to 4 weeks, and we have to keep a close follow-up. So this is a short video of the surgery that we did. So this, as I told you, this was almost 10 years back. The video quality is poor, but I would just go through the salient features. So this was a child from the Northeast, and you can see that the palpebral aperture was narrow, and we had to do canthotomy. And then the usual steps in Ahmed glaucoma valve was done, like the conjunctival incision was done, taking care not to injure the prominent vessels. I'll move a little bit forward. And then this is the pediatric FP8 Ahmed glaucoma valve that was primed. And the incision, the conjunctival dissection was done with the Stevens scissors, and the valve was implanted. And the tube, the antechamber was entered with a 23 gauge needle, and viscoelastic was left behind. The tube was fixed with 10-0 nylon, and the surgery was completed. So what happened in the post-operative period was very frightening, because on the first post-operative day, the child had only pale acute vision, and the tube was sandwiched between the cornea and the sclera. Only upper surface of the tube was visible. The tip was occluded by the iris, and the pupil was dragged towards the tube. There was peripheral iridocorneal touch and the central lens corneal touch. The pressure was high because the tube was occluded by the iris. It was 30 millimeters of mercury. And there was choroidal detachment with 360 degrees choroidal detachment and possible suprachoroidal hemorrhage. So we were very scared, and we started on conservative treatment like frequent doses of prednisolone acetate eye drop, moxifloxacin, atropine, tropicamide phenylephrine, and dorzolamide timolol we had to give because the pressure was high, and we also started on oral steroids. So post-operative day 2, the child had almost a similar picture. The AC was flat, the choroidal detachment was persisting, and we are now thinking whether we needed an AC reformation. So we waited for another few days, and meanwhile I consulted Dr. Anil Mandal from LV Prasad Eye Institute because he has very significant experience in this sort of cases, and he said to wait for another few days. And he said in many cases of shallow AC, postoperatively in such situations, the AC reformation can take place automatically. So we waited for a few days, and postoperative day 5, gradually the AC started forming, as you can see in the figure, in the photo, and the choroidal detachment was also becoming less. And postoperative day 15, it was much better. The vision was now 6/36. The pressure was 16 millimeter mercury on no glaucoma medication. AC was well formed, and the choroidals had resolved. So the take-home message from this simple case was that post-operative shallow AC with choroidal detachment can occur after Ahmed glaucoma valve in Sturge-Weber syndrome, even after taking adequate precautions. But fortunately, even a flat AC can reform with conservative management without AC reformation. Thank you.
Thank you, Dr. Debashish, for an elaborative and wonderful presentation that how nicely you handled such a tricky case of Sturge-Weber. So now I request Dr. Bhalla to share his experience about performing the prophylactic sclerotomies in these kind of eyes. So do you do it in a regular in your practice, or like for certain cases when there is choroidal thickness is more before the surgery you get to know, then you go for the sclerotomies? How do you go about these cases? We can't hear you, sir. Still, Dr. Bhalla is probably trying to reconnect with us. We take the opinion from Guru Satinder sir. So, what is your opinion on to that, sir? How to handle the? Okay, so Bhalla sir is back. So yes, so like how do you handle these Sturge-Webers in your clinics?
I think Dr. Devashish has published literature says that the results of both the valve surgery and the trab are the success rate and the qualified success rate with the better success rate with the valve surgery rather than with the trabeculectomy. And I think he's highlighted very nicely all the precautions and intraoperative ways to handle it. I'm sorry, I could not
Guru
hear most of the.
So we can hear you.
Okay, yeah. So I tend to go more towards valve surgery in these patients of Sturge-Weber syndrome, the primary valve surgery compared to that with trabeculectomy, because that is found that it works better in my hands, the results of valve surgery. I would like to have the opinion of other, particularly Dr. Hertz sir and also Dr. Shifali ma'am on this.
Shefali ma'am, can we have your opinion on this?
What Dr. Devashish has presented and managed very well. So in this type of Sturge-Weber syndrome, whenever we are
Hello.
we must remember the chances of choroidal effusion. What he has already presented,
Yes.
chances are very, very high, and we have to do conservative management here. Only thing is what he is telling about sclerectomy, and because these are the patient, because they were thick choroid, the chances of effusion are there because of this. So in this patient, if we do prophylactic, in the same sitting, we do sclerectomy with sclerotomy. That is what we do patient like in nanophthalmos also, because this is the patient whom the chances of choroidal effusion is high. So if you know the patient has thick choroid, then it is better to do sclerectomy with sclerotomy. We do it and we keep it open, the sclerotomy part, so that continuously it keeps on draining. That is one thing. And especially if the patient it is a child, this chances of hypertony is anyway high in these patients. Young age, and because of the high risk of choroidal effusion, we prefer to do sclerectomy with sclerotomy. And now of course the another thing is to give propranolol. The dose Dr. Devashish has already mentioned, 2 milligram per kilogram body weight, which we start pre-operatively. So that is what I will say. So whenever you are seeing, it is not only question of Sturge-Weber syndrome, whenever you are suspecting the chances of effusion are high, like a nanophthalmos, then there we can do prophylactic sclerectomy with sclerotomy.
Ma'am, that's very true. Only thing, like in your practice, have you ever come across, like, have you seen the difference of the incidence of the cases when there is a upper lid? Like, usually that's the cause of the fifth nerve is affected. That's a trigeminal. So when there is upper lid involvement, what I have come across is when there is a single lid involvement, the occurrence of secondary glaucoma is less as compared to both the lids are involved. So what do you say about it? Now, have you observed this kind of practice in your clinical scenarios?
No, I think I haven't.
Okay. And
So,
yes,
Shweta, I think they are all theoretically very, very correct, but it is so much easier to do a trap. And especially when you get into these kind of situations where the chambers get very shallow, then having a tube over there really takes your heartbeat off. So there's absolutely no harm, because we have done so many traps, and a lot of I went to PGI that day to give some lecture, and they have also done so many traps. So I don't really think that one can jump on the tube straight away, just citing the literature. And these are kids who are going to live forever and ever, and the chances of later tube exposure, things like that, are also very much there, especially in our country scenario where the later follow-ups may not be that good. And but what Shafali said about the sclerotomy is perfectly right. And they were presenting a case in PGI, also did the sclerotomy, and then they closed it. So she very rightly said that once you do a sclerotomy, leave it open, because that is the critical thing. because it'll keep draining over there. Yes, if you are thinking that it is going to flatten out later, like he very rightly, Devasi said, wonderfully presented, that yeah, you can fill it with visco. You can even leave Helon or viscoat as well, because sooner or later it will go out of the tube, but it will maintain it for quite some time. And that we do it even while we are doing trabeculectomies.
Yes, for the younger individuals, sir.
The
When we
these,
bring down the yes,
yeah.
yes, of course, we do it for the plain trabeculectomies also. And so just one more thing, like with your clinical experience, like everywhere, everybody's saying, Debashish also said, कि propranolol use kar rahe hain these days. Are you using propranolol in your clinic, sir?
Yeah, actually, when I first started, I thought I had discovered it. Then I came to know that Sushmita has a big paper on that. So yes, pre-operative. So actually, I asked her then the dose and everything. So yes, I think it is worth it.
Can I
And
say
what is the
something,
dose, sir?
Shweta?
नहीं मैं तो
Sir,
अभी
ma'am?
तो yeah, ask, he's already given
2
that.
milligram per kilogram body weight, and it is
आपने
started.
use किया है, ma'am? How it behaves, ma'am?
It is divided. It is given. It basically it constricts the blood vessels. I think that is
Yes,
the
हाँ.
this thing,
Hmm.
and it is given. It
Hmm.
started 1 week before in 2 divided doses. You know that 2 milligram per kilogram body weight. It is given as a BD dose. Start 1 week before and continue 6 weeks post-operatively. That is what is the recommended dose.
And you have to be
But
careful
we
of
have to
side
check the
effects.
pulse rate. Pulse rate is very
Systemic
important. So
side
that,
effects can be there without your knowing that.
yes.
Yes, that's very important point, sir.
One
Uh,
important point I want to just comment here what Debashish, because he mentioned specifically that he discusses Dr. Mandal, because I think one of the important, the mistake that people do once they see this type of hypotony, shallow AC and endothelial touch or this thing, they try to intervene. But here, conservative management observation is very important. So that is what is, because an AC will start forming whatever the conservative management which is given. So that is very important message.
Yes,
Any
Shafali.
general ophthalmologist
yes.
usually they
Yes.
panic, and I have seen
Ah,
patient going daily into the OT and forming the anterior chambers.
yes, very importantly said, very
That's
nicely
very
said.
true.
Because if
That's
there's
very true.
a choroid over there, unless the choroids are gone, this is not going to settle down, whatever you inject.
Yes.
So this is
Yes.
a very good message Shafali has given.
Yes, sir. I think that was a nice
To intervene,
sir.
that you would have to actually drain the choroids. If the choroids are too large, they are not settling down with conservative, then you have to drain the choroids. And then only you inject something inside and put a AC maintainer and then do the whole stuff. But without that, you just inject Helon and think the second day it will be the same.
Yeah, the pathogenesis is the same now, sir.
Yeah,
It's not, we are not taking care of it.
excellent point.
So, sir, so thank you for a nice discussion. Now we again quickly shift to because we've got two more cases to be presented today. So we quickly shift to the presenter, Dr. Vinita Ramnani. She's known to everybody now. And ma'am is going to present a case on a neovascular glaucoma. Over to you, ma'am.
Hello, am I
Yes, ma'am, we can
audible and
see the
visible?
slides. Yes, ma'am. Only thing is the slides need to be maximized to the full screen view.
Yeah. So thank you, Dr. Shweta, Dr. Mona, and AIUS for giving me this opportunity. I will be talking about the neovascular glaucoma blinding end. So 68 years male presented to me with the blurring of vision in both eyes with a poorly controlled hypertension and diabetes and triple vessel disease with an
Ma'am, the
ejection
slides are
fraction.
not changing. Ma'am, the slides are not changing.
I am on one slide now. Is it visible?
Yes, ma'am.
This is my first slide. This is my second slide. Is it
Okay,
visible
ma'am.
now? Yeah. So
No,
the
ma'am.
no, it's only on
First,
first only.
Can you do me a favor, doctor? Can you just stop share for a minute?
Okay. Did
Just
it?
click on share screen button once. Don't go sharing. Just click on the share once.
Okay.
Left hand side top, there is an option called entire screen. Just select that.
Okay.
Now go sharing.
Can you see my second slide now?
Perfect, doctor.
Yes, ma'am. Yes, ma'am.
Okay. So 68 years, male presented with the blurring of the vision with a poorly controlled diabetes and hypertension from more than 20 years. And he had a triple vessel disease with ejection fraction of 45, for which the CABG was advised, and he refused that surgery. So he's a poorly compliant patient with very uncontrolled diabetes and hypertension. Now I move my slides.
Just click on the screen, doctor. Just click on the screen and move the slides.
Okay. Yeah. So the ocular examination on presentation, the right eye has a best corrected visual acuity of 612 and 18, and left eye 624 and 636 with an intraocular pressure of 24 and 18. The gonio was open. There was no neovascularization at angle. There was no NVI, and there was a cortical and nuclear cataract. But unfortunately, both the eye had an extensive proliferative diabetic retinopathy with NVI and NVD. So when we did an OCT, it showed a multiple cystic spaces with extensive macular edema, hemorrhages, and this is the magnified view of an optic nerve where you can see the multiple vessels growing up. So it is a case of a very advanced proliferative diabetic retinopathy with cataract and neovascular glaucoma with uncontrolled systemic illnesses. He had nephropathy as well and cardiac involvement too. So the urea was 49 and creatinine was 2. So there was very high systemic illnesses. So the patient didn't get any fitness for the FFA, and we did the OCT, and the 3 loading doses of intravitreal anti-VEGF was injected, and the edema was reducing and the patient was improving, and even the vision was improving in both the eyes. The patient was doing well. We did multiple laser settings for this patient. So this is after something like 8 months for the intravitreal injections and lasers, but then there was a lot of vascular occlusion, the pallar of the disc, because he had lot many systemic diseases with fluctuation. And because of that, we were not getting the fitness, but after the fitness, we did a combined glaucoma and cataract surgery. And this time I did a trabeculectomy with mitomycin C, and he improved to 6, 9, and 9 in both the eyes with 18 millimeters of intraocular pressure with 2 drugs. And he was doing pretty well with a settled macula. There was no macular edema, though there was a disc pallar, and there was a good laser marks, and he was doing very well. But unfortunately, COVID hit, and then he was lost to the follow-up. And this time, when after COVID, he came after a year or so, the best corrected visual acuity has reduced to 636, and count finger intraocular pressure went up to 24. And again, there was an extensive macular edema involving more on a left side. It's visible on the OCT. The macular thickness was very high in left side. So this is after a year when the patient came first in 2020, and now this is in 2021. So again, we started giving him intravitreal, but then every time when I was giving intravitreal, there was a problem because this patient was an CKD patient with every time the urea, creatinine, sugar, everything was so high, but then he was responding to anti-VEGF, and I give anti-VEGF again and again to reduce the intraocular pressure and maintain the macular thickness and the vision. And once we used to give anti-VEGF, the intraocular pressure used to become down, and it used to be a kind of a settled eye. So he used to come only for the injections. He used to go again, disappeared. Later on, when a stage came where the IOP went up to 40s and there was a lot of corneal edema, the disc pallar. That time we advised AGV, but then he went to the cardiologist for the fitness because the sugars were very high and the ejection fraction was very less. So I told him to get the cardiac fitness done so that we can do the AGV or refer you for the AGV. but unfortunately he had a cardiomyopathy and MI again, and he was admitted in the hospital for quite a long period of time, ejection fraction going further down to 20%. So I have given every time a red flag, which we are going to discuss for this patient. So every time that patient will be coming with the hope that the injection will do the miracle for him, and he always used to avoid the surgeries, and because of that the disc went on to the optic atrophy and he was losing the vision, and off and on the macular edema used to come because his sugars I have never seen within a normal range. The urea, creatinine, everything was so high, and now on top of it he has an uncontrolled neovascular glaucoma, which was again a problem for us. And these are the injections, like multiple injections in the right and left and multiple lasers being done to control the ischemia and neovascularization. Unfortunately, because he was not improving, he shifted to some another place. And then when he came from the beginning of 2020 to 2024, he has an end stage progressive diabetic retinopathy. Though he had an uncontrolled neovascular glaucoma also, now this time he developed an extensive vitreous hemorrhage, a proliferative tractional band in the right eye, and probably a loss of a right eye with only a hand movement vision. Left eye luckily was not that bad, but because of the ischemia and because of the hemorrhage, again the fresh hemorrhages which has developed in spite of so many intravitreal injections and the lasers, that vision dropped down to 2/60. And this time this fellow is saying do something, and Dr. Hirsch has done an AGV for this patient. The pressure was maintained, the eye was the same, stable, but then he had only a count finger vision. He survived only 6 months after that AGV. So it's a kind of a last battle, and he passed away because of so many systemic illnesses. So the red flag for this patient is a delayed presentation. So when you see the first time picture, the patient has an extensive NVE and NVI. So the diabetic screening plays a very important role. Then secondly is uncontrolled systemic condition. So that is utmost important. Until unless you don't control the diabetes or the concern illness, the patient is not going to be happy or controlled from the eyesight. And in this patient, there was multi-system involvement, and all the involvements in the kidney or heart were very extensive, and they worsened the retinopathy and delayed definitive surgery. So timely intervention is key to preserve the vision. And lastly is the non-compliance. This patient was not on a regular follow-up. So these were the 5 red flags for this patient to reach to the blinding and for a neovascular glaucoma. So as neovascular glaucoma, as it is a potentially blinding disease, it has an intractable aggressive course. It is a secondary angle closer glaucoma variety, and it is going to take away the vision because the problem is in the posterior segment, so which takes a lot of brunt of vision, and the urgent management is imperative. And we did lot of injections for this patient, PRP, glaucoma surgery, but the regular follow-up is important. And unfortunately, we were not able to reverse the rubiotic rampant in this patient, maybe because of the multi-system disorder. So unfortunately, the disease kept on progressing, and the efficient systemic control, which we were thinking to be get into, we failed to achieve those systemic controls, and the disease progressed and the patient lost vision. So nonetheless, if you control everything, still there are 3 to 48% of the patients which may lose vision. So the neovascular glaucoma is a very serious sight threatening condition, especially if it is with the cardiovascular diseases. So prevention is a key, and we should go on hammering the patient for this neovascular glaucoma, and we should wither the storm of neovascular glaucoma, especially in a high risk patient, which is the key. So AIOS and many doctors and many people at their own level initiate the diabetic screening. That is the way to prevent the neovascularization. Thank you so much for the patience hearing.
Thank you, ma'am. Indeed, it was a elaborative. Yes, again, I'll say a precise presentation on neovascular glaucoma, one of the most intractable glaucomas when it comes to the secondary glaucomas. So, Shifali, ma'am, you've been handling a lot of neovascular glaucomas, though Vinita, ma'am, has covered all the points. But would you like to add on to something, ma'am, with your clinical expertise?
I think I would have managed this case little bit different. I agree with Dr. Vanita completely that yes, NVG is a condition. I think out of all secondary glaucomas, this is condition which needs prompt management. And usually it deals with not only glaucoma but retina. You have to have not you means basically it should be managed by the two teams, retina team. Even if you are giving injections, but it has to be managed by the retina people. That is one thing. And second, I think in this case, because what she presented was that the patient had CME to begin with, and pressure was little bit high. So in this patient, if the pressure was under control with medication, and once your anti-VEGF and the was given, and for PDR, if the fill in PRP is already done, means you are with your retina team, and you know that now your patient it is under control. Your this part NVI and NVA part. I would have gone in this patient for cataract surgery first. Even if these are the patients, we know that patient is going to develop cataract maybe in near future, and these are the patients. If these other parameters are not under control or patient gets recurrent edema, then usually patient will keep on shuffling between the retina doctor between and you will not do cataract because patient has macular edema, and they will not advise because I cannot see because there is a cataract. So these are the patients I usually advise cataract whenever edema is resolved with anti-VEGF. PRP is under, that adequate PRP has been done. And also second thing, in future if you need glaucoma surgery, these are the patient you will need glaucoma surgery, that because your follow-up has to be very frequent in neovascular glaucoma. It should be not 4 to 6 months, it has to be frequent. And these are the patient we know that you will need to do glaucoma surgery. So when you do cataract surgery, you are creating a space in the posterior chamber anyway, because tube. I prefer in this patient tube rather than the trab, because chances of the trabeculectomy failure is extremely high. That is what I have seen. And second, one of the very important thing what I have seen, because our patients who are shifting between the retina who are outside, usually retina doctors, they once it is clear no, so they say कि अभी 1 साल के बाद जाना. But these are the patients you need to monitor, and every time when you see the patient, maybe 2 monthly, 3 monthly, you have to actively look for whether is there any sign of NVI or new NVA, and then definitely you can save this vision. So what Dr. Vanita said, that NVG is a preventable disease. Vision can be saved only, but it needs your proper attention. Whenever patient is coming to you of NVG, you have to look actively for NVI and NVA. If it is there, that means again this patient needs, that means there is ischemia, and this patient needs another maybe fill in PRP, maybe anti-VEGF. That is what I will say. And you can save the vision.
Okay, thank you, Shifali. I think that was wonderfully said, but I will beg to differ on 2, 3 points. Number one, we are only thinking of ourselves. This patient, I've seen this patient, and I did the valve only. I didn't do a trab in this case. Okay, he has so many problems. There is a leg ulcer, there is a gangrene, there is a kidney problem, there is this thing to be done, there's a dialysis to be done. And do you think this person will think about the eye? It will be lucky to get them, exactly like Vanita said. It takes a long time, and this is anyway, these are very, very sad cases. And when the neovascularization cannot be controlled by so many things, that this patient is going to go, because the vessels not only of this place but of the kidney are going to go, and whatever you do is cardiac, this thing is going to go. This is the problem. Second thing, if this is there's a set of patients like this in which you really can't do much, but in the set of patients which are okay, things are doing well, okay, you have to do a surgery. I think especially for people in the periphery, please don't wait, because you don't know how to do a valve. A trap does wonderfully well, and I've done so many of traps. You see that the adequate PRP is there, give an injection 3 days before doing a trap, so that the NVI disappears, and then do a trap, the mito has to be a little extra over there. And sometimes I take a little bit of anti-VEGF and put it in the bleb also. So if you cannot send the patient to do a valve, you don't know how to do a valve, please go ahead and do a trap. Don't worry about that part. But yes, it, like both of them said, it is a preventable thing and you have to be at it. So wonderfully discussed, Shefali, and wonderful presentation by ma'am.
Dr. Vinita, yeah.
So, with that, we come to the end of today's discussion about the secondary glaucomas. Unfortunately, Dr. Shalini Mohan ma'am's flight has got delayed a bit. So, I would request Harshas to give the closing remarks, how to deal with the secondary glaucomas for the audience, sir. Over to you, sir.
No, I think we have already discussed quite a bit. And
Sir,
we
but
just want to thank AIOS and especially Shweta for really convening this on this juncture. And it was a wonderful, all the presenters were wonderful. And so were the discussants. So I think we really had a gem of a time. I also learned so many things. And that is the beauty of this presentation. So I think really it was wonderful. I think Shweta can thank each one of them in turn as the
course, sir.
closing remarks. And thank you very much, Shweta, for
Yes.
having us here.
Sir, yes, thank you very much, sir, for your kind words. And on behalf of Dr. Manoj Mathur, sir, it's my privilege to propose the vote of thanks for today's session, insightful discussion on secondary glaucomas. I would like to express my sincere, deep gratitude to our esteemed chairperson, Dr. Harsh Kumar, sir, who himself, once again, though he doesn't need to prove himself that he's a stalwart of glaucoma, but yes, again, once again, we are glad to have Harsh, sir, with us on this platform. He has made today's session truly insightful with all his clinical pearls. Along with that, the discussants, as Sir said, Shefali ma'am, Shibal ma'am, Dr. Phalla, Dr. Gursitandar, everybody had really contributed a lot and shared a roadmap for the management of each of the cases. Last but not the least would be our dynamic speakers, without whom we could have not ever concluded this session at all. They made a novel clinical challenge. They put forward all the best of the cases possible and the best way to deal with those secondary glaucomas. Kavita ma'am and all the speakers, Dr. Debashish, Dr. Shayanur, Dr. Preeti, Dr. Vinita ma'am. Thank you, all of you, and good night from my side. Thank you, everyone. Take care and have a lovely weekend. And thank you for sparing your time over the weekend, and that too on a Valentine's Day. So, and yes, of course, it goes unsaid. Thanking my co-moderator Mona ma'am, as she's always there. The minute I get the opportunity from the AIOS, my first call goes to ma'am. Ma'am, we are again moderating a session together. So thank you, Mona ma'am. Thank you for being there.
Thank you, Dr. Shweta.
Bye, good night.
Thanks for inviting.